Hello, my name is Danielle Carlson. I'm a research technologist at Mayo Clinic, and today I want to talk to you about our work on the utility of FDG PET scans in patients with newly diagnosed pancreatic cancer. Pancreatic cancer, specifically pancreatic ductal adenocarcinoma, is a highly aggressive and lethal malignancy due to its predilection to spread or metastasize very early in up to 50% of patients at the time of diagnosis. Surgical resection is the only curative option, more recently combined with neoadjuvant or preoperative chemotherapy to improve survival outcomes. For initial chemotherapy to actually be beneficial, we must objectively demonstrate responses to that neoadjuvant chemotherapy prior to surgery. However, this has been elusive. Traditional ways to measure a chemotherapy response have not been helpful. Tumor shrinkage on CT or MRI scans is uncommon and cannot be shown to predict survival outcomes. Decreases in blood tumor markers such as CA19-9 is not possible in nearly 40% of patients, hence significant limitations with these commonly used response modalities. As a result, the 2023 NCCN guidelines included FDG PET scans as an adjunctive modality to assess neoadjuvant chemotherapeutic response in pancreatic cancer. Living cancer uses glucose for energy. For an FDG PET scan, we inject patients with radioactive glucose, and this gets taken up by active cancer cells. These can be visualized as metabolic hotspots or tumor avidity with the quantitative activity levels or SUVs. However, there is a paucity in data due to the misconceptions on the tumor avidity in untreated pancreatic cancer. It is necessary to utilize FDG PET scans for therapeutic assessment during treatment. So, we aim to describe the baseline characteristics and utility of FDG PET scans in a cohort of 1,000 pathologically confirmed and treatment-naive PDAC patients as part of a single-center retrospective study. We discovered that overall, 96% of patients had FDG-avid primary pancreatic tumors with an average SUV over 6. FDG PET scans also identified suspicious metastatic lesions in 50% of patients overall. These results show that the majority of newly diagnosed pancreatic cancers have tumors that are FDG-avid and thus can be visualized and monitored over time to assess metabolic activity changes to neoadjuvant chemotherapy combined with the other traditional response modalities. Furthermore, FDG PET can improve staging of patients by detecting suspicious metastatic lesions, with PET MRI being superior to the standard PET CT in visualizing some of these lesions. Our study provides evidence to support the routine use of baseline FDG PET scans in treatment-naive pancreatic cancer, as the overwhelming majority have tumors with measurable metabolic activity that we can follow to assess responses over time. FDG PET scans can also improve baseline staging to significantly aid surgical decisions for patients. The accumulating evidence on the roles of FDG PET for initial baseline staging and response assessment during chemotherapy justifies its inclusion in the pancreatic cancer treatment guidelines. I would like to thank my mentor, Dr. J Truty, and all of my co-authors for their support in this project. Thank you.